One of the greatest obstacles to crafting health and wellness is identifying and controlling inflammation. It's at the core of all complex and chronic diseases, and it's the driving mechanism that underlies the most common symptoms that people like you struggle to overcome. Join us as we explore cutting-edge science and research to give you the information and tools you need to create the quality of life you want and deserve. And now, here is the host of Inflammation Nation, Dr. Stephen Noseworthy.
Hey, good morning, everybody. We're back with the Inflammation Nation podcast. If you're watching this on YouTube and you see the video, you can tell I'm actually in a hotel room. I'm recording this very early in the morning here in Minneapolis, Minnesota. I was here this weekend teaching a group of doctors about what we call functional blood chemistry analysis. And it's just an alternative way to look at laboratory testing that seeks to determine optimal health rather than identifying disease and pathology, which of course is what the conventional system is for. But if you feel like my voice is a little bit low, it's because I've been talking for 2 days straight, but also it's very early in the morning and I've got to be off to catch a plane back to Eastern Canada today. It's going to be a long travel day. So I'm just trying to be quiet so I don't interrupt anybody or wake anybody up in the next room, for example. So we're going to continue on. This might be the last, it might not be the last episode in the heart health cardiovascular risk aspect of this functional hierarchy of health. And today I'm just going to dive right in and we're going to talk about some of the best tests to assess your cardiovascular disease risk. And to be honest, one of the first ones is really not a test. It's just simply a question. And that question is, do or did your parents or older siblings experience heart disease or die young from heart disease? And so it turns out that a strong family history of early heart disease is one of the strongest predictors for you as an individual, right? And so if you answer yes to that question, then you need to take your own other specific risk variables and your general metabolic health that much more seriously, because it kind of ups the stakes and increases the probability that you're going to struggle with the same thing. I have a client that I worked with for years, and when he first contacted me close to, I guess it was about 15 years ago, his main concern was his heart, because his father had died of a heart attack at the age of 57. And when he first contacted me, he was something like 56, or, he was right around the age that his dad died in 56, 57. That's pretty young to die of a heart attack. Pardon me. And he said to me, tell you the truth, Doc, I'm scared to death. Now, he's done quite well. He's not quite 20 years older. Well, I guess he is, 15 to 20 years older than when his father died. And his risk markers are now, and have been for a while, they're under control. So we've really mitigated his risk despite this, very, very concerning family history of early heart disease. And that's one of the key things, right? So strong family history is the first thing to think about, and then to start to act accordingly. And so once you settle that in your mind, just give me 1 second here. I got a couple of things to click on my screen. Once you settle that in your mind, the next thing to think about is blood pressure and your general metabolic health, right? Focusing first as it relates to metabolic health on things like blood sugar control, inflammation, and obesity, if that picture fits you. Pardon me. And it's not like you need all these at the same time, or that if you don't, then you don't have to worry. Hypertension by itself is a big driver of this thing called endothelial dysfunction, which is where arterial plaquing starts. And I'll come back to that, but you can be hypertensive and not be obese or not be a pre-diabetic. And that high blood pressure alone is a problem, especially over time. But if we could describe a ticking time bomb as it relates to the risk for heart disease or stroke, it really doesn't get any worse than being an overweight, hypertensive type 2 diabetic who's chronically inflamed and who has a strong family history of early heart disease, right? It doesn't get any worse than that. I guess it could if you were a smoker, right? Smoking's at the top of the list. Now that's the extreme. And risk is reduced for any one of these things that you don't have or everything that you can eliminate or control. But let me be pretty clear that, maybe you're not overweight and maybe you don't have high blood sugar or high blood pressure. That does not mean you don't have any risk, because there are other independent risk factors. For example, an elevated homocysteine level. And this is something that, at least I measure on a routine basis, just because of the strong connection of chronically elevated homocysteine levels to heart disease as well as to neurodegeneration, like things like dementia, Parkinson's, Alzheimer's. So let me take a few minutes and explain this as simply as I can, because like I said, everybody has risk. And the simple fact of aging can increase the chance of this thing called endothelial dysfunction, which I just said, this is where plaque begins. So let me go through this thing called endothelial dysfunction. You've heard me talk in other episodes and other mini-series about the barrier systems. Now, barrier systems keep our internal environment separate from the external environment, and they're a big part of how we stay healthy. It's for our barrier systems to be intact and to be optimized. And again, you've heard me talk about specific barrier systems like the gut barrier, which prevents toxins, infections, and even partially digested proteins from food particles, prevents those from slipping through the gut into the bloodstream. We also have a lung barrier, which prevents things like persistent lung infections and chronic bronchitis and pneumonia and respiratory issues. And we also have the blood-brain barrier, which protects the very delicate brain environment and only lets certain things get inside. And we just have to deal with the fact that the brain is the most metabolically sensitive system that we have. And that is the essence of a barrier system. It's to let some things pass and to exclude others. Exclude things that if they got past the barrier would cause problems that we don't want. So back when leaky gut became a big deal clinically and in research, the researchers were talking about the vascular endothelium as the next great barrier system. And it really is, right? So just like the lining of your gut, the lining of your lungs, and the blood-brain barrier, your blood vessels are lined with what are called endothelial cells that form the inside of the blood vessel tube. And because this is the lining of your arteries and veins, they're in constant contact with your blood and everything that's in it. And it's these very cells that make up the vascular barrier, or the vascular endothelium, which is a barrier system. Now, there's an awful lot of stuff that's floating around in your bloodstream that has no business getting through this endothelial lining, right? Because if they did, it would set off a chain reaction of events that could lead to this whole concept of plaquing. And one cool thing about these endothelial cells is that they are hormonally active, meaning that they make stuff that act like hormones that keep themselves healthy. And one of those things is nitric oxide, which you've heard me mention before. And nitric oxide is becoming better known in clinical settings. I've been teaching different aspects about nitric oxide physiology for, I'm going to say, maybe around 10 years or so now. But we're now seeing supplement companies coming out with nutritional products to help support this nitric oxide pathway. And some are helpful and others are honestly complete garbage and a waste of money. You see a lot of athletes, bodybuilders, weightlifters are using nitric oxide boosters to get what we call the pump, or to improve the efficacy of their workouts. And again, there are some good products, but many are bad in this regard. But let me tell you what nitric oxide is and what it does, and then we can talk about these trigger events that lead to endothelial dysfunction and plaque formation. So we get nitric oxide two ways. I'm just going to call them the intrinsic and the extrinsic pathways. The extrinsic pathway, meaning outside, and this is my terminology here. This is where bacteria that are on the back of your tongue process dietary nitrites and nitrates to make nitric oxide. And as we eat food that has these nitrates and nitrites in them, these bacteria metabolize that, it mixes with our saliva, and then we swallow it. And there's nitric oxide in that. So we're not making the nitric oxide, but bacteria that live in our mouths are, as long as we have a few things in place. Number one, we have to have a dietary source of nitrites and nitrates. And the bulk of this comes from things like leafy green vegetables, but that's not the only place. Like we also find nitrites and nitrates in things like hot dogs and cured and smoked meats. And all the things that you've been told to stay away from actually contain the base molecule that these oral bacteria use to make nitric oxide on our behalf. I recently interviewed one of the top nitric oxide researchers on my doctor-focused podcast, the one called Funk Med Nation. His name is Dr. Nathan Bryan. He's from Austin, Texas. And I asked him if we could ever eat enough hot dogs and salami to actually cause cancer. And the question made him laugh. So it turns out that this idea that things like hot dogs and cured meats cause cancer came from the very early nitric oxide research well, I shouldn't say nitric oxide research because that was discovered later, but very early nitrite and nitrate research of the 1950s. So what they thought back then was that eating these things called nitrites and nitrates could increase something called secondary nitrosamines, which could potentially cause cancer. And that part is true. But this was before they discovered that nitrites and nitrates are actually the precursors and the source material to make nitric oxide, which is really good for you. And while a portion of nitrites and nitrates can be converted into the secondary amines that can potentially cause cancer, the reality is that something as simple as ascorbic acid or vitamin C shuts that down and can prevent it. Plus, you have to eat a god-awful amount of hot dogs and cured meats in your lifetime to make that happen. Right? So the likelihood of that is actually very, very low. You might want to limit those types of foods for other reasons, but the message is don't fear nitrites and nitrates. They're actually good for you. So the first thing is a dietary supply of those things. The second thing that you need to have a good oral microbiome. That's the probiotics that live in your mouth and particularly live on your tongue. And so, like I said earlier, these bacteria live on the back part of your tongue. They munch on the nitrites and nitrates from leafy greens or hot dogs and bacon and cured meats that you're eating, and they create nitric oxide that we swallow. But you need to have these bacteria present. It's not enough to eat foods that have nitrites and nitrates in them. You have to have these bacteria present in your mouth, and there's one very common lifestyle habit that many people have that devastates these bacteria and prevents you from taking the nitrites and nitrates in the leafy greens and bacon and cured meats to make nitric oxide, and that lifestyle habit is mouthwash. So it turns out that Dr. Bryan published data in a study where they measured nitric oxide production after 1 week of routine mouthwash. And not only did they see that the nitric oxide levels went down, they saw that blood pressure actually went up. And then they reversed it. They took the mouthwash away and the oral microbiome came back. Nitric oxide production improved and blood pressure went back to normal again. In his words, Dr. Bryan said, when Listerine says that their mouthwash kills 99.99% of bacteria, he said, believe them. And that includes all the good stuff that convert these dietary sources into nitric oxide, which then have protective effects, not just on your heart and your blood vessels, but they're good for your immune system and also really good for your brain. So this is pretty cool stuff, right? So if you're using mouthwash, please stop. And I know it might sound weird. Who doesn't like a fresh, clean mouth? But it's killing your oral bacteria and tanking your extrinsic nitric oxide production, which, by the way, makes up about 50% of all the nitric oxide in your body. That's huge. So one simple strategy can help to improve that. Now, the other 50% of nitric oxide that is in your body comes from this intrinsic pathway, like what happens inside your body. This is where we make nitric oxide ourselves, and we don't rely on others like bacteria to do it for us. And to do that, we use an amino acid called arginine and a set of enzymes called nitric oxide synthase. NOS is how it's typically abbreviated. We might call it NOS. Now, there are 3 types of these NOS enzymes. Again, that stands for nitric oxide synthase, that are specific to either the blood vessels, or another one is specific to your brain and your nervous system tissue, and the third is specific to your immune system. So there's 3 versions of this NOS enzyme. And they all use arginine to make nitric oxide. And the nitric oxide that they make is all the same. So nitric oxide is nitric oxide is nitric oxide, but we have 3 different enzyme pathways that are distinct to different parts of our bodies, brain, blood vessels, and immune system, that make the same nitric oxide. So it doesn't matter which enzyme system makes it, the nitric oxide is all the same, it does the same stuff. But that's, a much bigger conversation. So today what I want to do is focus on the blood vessel part of the system, which is where the enzyme called eNOS, and E stands for endothelial, and eNOS stands for endothelial nitric oxide synthase. So this enzyme associated with your blood vessels takes arginine and makes nitric oxide. And this nitric oxide made by the blood vessels does a few predictable things. First of all, it relaxes and dilates your blood vessels, which means that your blood flow kind of slows down as it goes through your tissues, and that makes it easier for your cells to pick up nutrients like oxygen and glucose and vitamins and minerals and so on. But the relaxation response also reduces high blood pressure. Now, if you have normal or low blood pressure, optimizing your nitric oxide does not reduce your blood pressure from there, but it does reduce high blood pressure. So that's the first thing. The second thing is that nitric oxide produced by the blood vessels protects the cells of the blood vessels, the cells of the vascular endothelium, from injury or inflammation. And it prevents the very trigger that starts the whole plaquing process to begin with. And on top of that, nitric oxide produced by your blood vessels has been shown to reduce plaque that has already been created. Now, nitric oxide does other things here, but if those 3 don't grab your attention, reducing blood pressure, preventing inflammation in your blood vessels and the trigger event for plaque, and reducing plaque that's already there, if those don't grab your attention, I'm not sure anything will. This is an astounding molecule. So let me back up for just a second, because I know someone's probably out there listening is saying to themselves that all I have to do is take arginine as a supplement. And this is a very common thing that's being promoted in functional medicine practices, also in the health and fitness industry. Some of you might have already seen or are already taking arginine or another amino acid called citrulline, which can then be converted to arginine, which then can be converted into nitric oxide, trusting that by doing those things, that taking extra arginine, you're going to make more nitric oxide. And it's a good thought, at least on paper, but it doesn't work that way inside the body. So we have studies on ICU patients, very sick people who have poor blood flow, they have poor vascular health, they have blood pressure issues. Their nitric oxide levels that improve blood flow and reduce BP are way down, and giving them arginine or citrulline doesn't change that. We have studies published on this, right? These people die from end organ failure because they can't get blood and oxygen into their tissues because their nitric oxide is in the basement. So if their nitric oxide is low and we make nitric oxide from arginine or citrulline, why doesn't giving it help? And the answer is that even with critically ill people who are, say, septicemic, they have more than enough arginine in their bodies to saturate their nitric oxide synthase enzymes. They already have enough, so giving them more doesn't help. You can't force the system to make more when the limitation is not the supply of arginine, it's coming from some other place. So it's like if you're buying a box. I'm trying to come up with an analogy that might work here, right? You need to buy a box, and you only need one specific box of a specific size, and you have enough money to buy it. But if I give you more money when you already have enough, that doesn't help you buy the box because you already have enough money. Now, maybe it's a bad analogy because who doesn't like extra money, right? But the bottom line is that we all have enough arginine and citrulline in our bodies already, even when we're sick, that if there was no other obstacle to make nitric oxide, we can't make more by giving more arginine. We already have enough. So, people who are chronically ill and systemically inflamed, again, the problem is not a lack of raw materials from which we can create nitric oxide. There is something else that's blocking the conversion process that we have all the raw materials we need, but you just simply can't make it. So it's like showing up to the box store with your money in hand only to realize that the store is closed. Having more money at that point doesn't help you. So it turns out the rate limiting factor in how much nitric oxide we can make through either this blood vessel associated nitric oxide system or the one that's associated with your brain and your immune system, the limiting factor is the amount of what's called BH4 that we have available. And BH4 is just the shorthand for a vitamin B9 derivative called tetrahydrofolate. Now this biochemistry gets complicated very quickly, right? Because to understand it requires knowledge of several different biochemical pathways and how they intersect with each other. So let me short list this for you and tell you the main things that can take down your BH4 and as a result decrease your nitric oxide and put your heart health at risk. So in order to have enough BH4, you need, first thing, you need normal energy mechanics. Like you need to be able to produce this thing called ATP that we've talked about before. But not only just ATP, there is a close cousin to ATP called GTP, which has the same energy value as ATP, but it's got, again, it can get very complicated. It has a guanosine base instead of an adenosine base. This is the immediate precursor. This GTP thing, which is a product of producing energy, is an immediate precursor to this thing called BH4. And so we make BH4, which is the limiting step in nitric oxide production, as a consequence of making energy. So anything that interferes with energy in GTP production can reduce this guanosine availability, which means that your BH4 goes down, which means that nitric oxide goes down, which means that you lose heart protection. But we can't make guanosine ourselves. We get it from our diet. You have to have adequate protein in your diet to get this thing called guanosine. So the second thing that you need is adequate protein in your diet. And I've talked many times about how much protein you need to eat, and go back and listen to, it's kind of a long series, but the whole series on like creating your ideal diet. So you can just search through that in the podcast list if you want to. So you need adequate protein, and you have to have the ability to digest and absorb it, to supply this thing called guanine, from which we make guanosine, and from which we make BH4, which allows us to make nitric oxide, and away we go again. So low protein diets or plant-based diets that have a lower guanine content can be an issue. So too are problems with things like stomach acid and protein maldigestion. You might be eating enough protein, but if you can't break it down because you don't have enough stomach acid, you're not getting out of that protein what you should. Or we might have things like infections or leaky gut that can lead to malabsorption. So there's any number of ways that we can interfere with this process. And finally, you have to have a normal functioning methylation pathway, what's commonly called the MTHFR pathway, which is how we basically recycle and keep using BH4 once we have it. BH4 is used and regenerated when this methylation cycle works properly, is a better way to say it perhaps. So if you have some of these common MTHFR polymorphisms on gene testing, then you're a poor methylator. Your BH4 is not good by definition. And the sign that it is a problem, it's not enough just to have this polymorphism. You have to have evidence that it's actually not functioning well, and that would be like by looking at this homocysteine, which I mentioned earlier. And if your homocysteine levels are in the double digits, like in the teens and certainly higher in the 20s and 30s, the higher it is, the worse the problem is. So you can very simply look at your homocysteine levels to see whether or not your methylation pathways are working. And we'd like to see those in single digits for sure. So you can see that there's a lot to the story. Right, nitric oxide is absolutely critical to heart health, but it can go wrong quite easily, and most studies support the notion that all cardiovascular disease involves nitric oxide dysregulation and or deficiency. So what does this have to do with testing? Because this is supposed to be about testing. Well, I mean, it's not so much with actual lipid tests, and also not with nitric oxide testing, because there is no test that we have for nitric oxide. Nitric oxide is a gas with a half-life of less than 1 second. So that means it's here and it's gone, like in a snap. And while I'm on that subject, there is a saliva test for nitric oxide that Dr. Bryan invented years ago. It's being sold under a couple of different brand names right now. You might have seen one of them on social media last year or so from a company called Human N. But here's the deal. It's marketed as if the saliva test can tell you how much nitric oxide is in your body, and it does not. It's a saliva test. It actually tells you about whether or not those bacteria in your mouth are making nitric oxide in your mouth. It doesn't tell you about how much is in your body, because at best, the oral microbiome way, the extrinsic pathway, can account for only up to 50% of your total nitric oxide production. So it simply can't and doesn't tell you if you're making it yourself using arginine and nitric oxide synthase enzymes. So remember, the oral route, the dietary oral bacteria route, can only make 50% of the whole picture. So maybe your saliva nitric oxide test is fine, that's only half the story. But if you have a problem with the intrinsic pathway and how your body is converting arginine, that's a big deal. So you can be fooled very easily into thinking that everything's fine. But to be transparent, I've done the saliva test with myself and lots of clients in the past, and that was back before I knew more. And this is, maybe a good time to to reiterate to you guys, like, I don't know everything. I'm on a journey of learning, and it's been a great 15, 20 years. I've learned so much, but I continue to learn. I'm not silly enough or foolish enough to think that I know everything. And I think that if any, just a word of caution to you guys as you listen to podcasts and listen to people that are out there in the space promoting, education or their services or whatever, nobody knows everything. It's very easy to portray yourself that way, but nobody knows everything, and that includes myself. So anyways, but back to the saliva test, there was a time when I would do this, but I started to question the clinical relevance of this when I started having them not just do a single test and decide from there if their nitric oxide was fine, but I would have them do the test at different times of the day and for several days in a row. And the results for most people were very inconsistent. On one day it was great, the next day it was not. It was great in the morning, it was worse in the evening, or vice versa. And this is because the activity of your oral microbiome is highly variable. And that means that things like the food that you eat, or what you've eaten most recently, what you're drinking, your toothbrushing habits, whether you're using mouthwash, even things like atmospheric pressure and temperature can interact with your oral microbiome and change what they do. And so that was, seeing this inconsistency was the first clue for me that there was something wrong with my thinking. And it was that observation that led me to start questioning what I knew or what I thought I knew about nitric oxide. So let's get back to this idea of testing, right? Remember that the first, I'm going to use air quotes if you're listening on the podcast, the first tests that you need to do are simple questions that you ask yourself and for your family history. Do I smoke? Of course you should stop. But you should ask yourself, do I have a family history of heart disease, especially early heart attack or stroke? Am I overweight? Am I inflamed? Do I have high blood pressure? Do I have high blood sugar? Do I eat enough protein and sources of nitrites and nitrates? Can I easily digest proteins, or do they feel like they sit in my stomach and they don't move along? Do I use mouthwash, or do I have some form of dental or periodontal disease? Am I tired? Do I have issues with energy production? And if I look at my labs, do I have a high homocysteine, and or do I have an active MTHFR gene defect or polymorphism? So those are the questions in questions/tests that you should probably start with. And I guess I'm going to do one more episode here. As far as blood tests go in your lipid panel, let me close this episode and maybe tease you for the next one, which will be the final one in the cardiovascular section, that there's one single aspect of your standard lipid panel that has the most predictive power for cardiovascular disease risk, and it's not your total cholesterol. It's not even your total LDL. This is something you can calculate from your lipid panel very simply without having to go to the next level of deeper testing and looking for your small dense LDL or your ApoB levels or the inflammatory markers of MPO or PLA2, or looking at the genetic risk marker of lipoprotein A. So I'm going to leave you there. I'm going to leave you hanging, and we're going to cover that the next time right here on the Inflammation Nation.